Hello, mic test. Those of you who are still in the back, we're about to start our program this afternoon at 2, I think, 2:01. So why don't we open our hymnal on page 462. 462, Blessed Assurance, Jesus is mine. We'll sing the first and third in stanza last. Yeah, so there's...
Good afternoon. Welcome to this afternoon presentation. I invite everyone to join us in the sanctuary. We'll start in a couple of minutes. People who are still in the fellowship hall, I would invite you to come to join us here. What are you looking for? What are you looking for?
I was looking for that stack of my papers that I brought through.
Right here.
So I'd hand those out last.
Okay. Yeah. Is the same copy?
Yeah, same thing.
Okay, that's good. We make 10 more copies. That's enough.
Hand those out first.
Yeah. Please join us. Please join us here in the sanctuary. Let's have a word of prayer. Our most gracious, loving Heavenly Father, we thank you so much for your Sabbath day. We thank you for the message that we heard this morning. And this afternoon we have another message. It's a health message that you would like us to learn and apply into our daily life. Send thy Holy Spirit to each one of us so that we can understand what we're going to learn this afternoon. In Jesus' name, amen. Good afternoon. Welcome to this year 11th health presentation. It is my honor and privilege to introduce to you our speaker, Dr. Robert Soderblom. affectionately known as Dr. Bob by his peers and students. Dr. Bob is a graduate of Loma Linda University School of Medicine, class of 1963. After graduation, he took an internship at Washington Sanitarium and Hospital in Tacoma Park, Maryland. Subsequently, Dr. Bob joined the U.S. Air Force with the rank of captain and stationed at James Connolly Air Force Base, Waco, Texas. From 1966 to 1969, he was a resident in internal medicine where, under the tutelage of Dr. Stuart Schenkel, he became interested in nephrology. From 1969 to 1971, he was offered a nephrology fellowship at Southwestern Medical School, Dallas, Parkland Hospital, University of Texas. In 1971, he was invited to be a professor at the School of Medicine, Loma Linda University. Soon thereafter, he became chief of nephrology and director of dialysis services. Besides his busy work, teaching and research, Dr. Bob has a passion for missionary projects. He ran a dialysis unit at Georgetown Adventist Hospital in British Guiana for 10 years. For nine times, he went to Kabul, Afghanistan, to teach Afghan doctors at the Waysar Akmal Khan Hospital. Dr. Bob was married to his late wife, Alice, for 57 years. They have 4 children, 11 grandchildren, and 2 great-grandchildren. Dr. Bob retired in 2020 and is now Professor Emeritus of the School of Medicine, Loma Linda University. Dr. Bob, what an impressive bio. Thank you for spending your precious time with us this Sabbath afternoon. The time is yours.
Thank you. Thank you very much. Can you hear me okay? I am used to my class usually sitting forward so I can see the whites of their eyes. When I don't see the whites of their eyes, I know I have done something wrong, okay? So if you want to test me out on that, you're welcome to move forward so I feel like I'm communicating. But if you don't, okay. But okay. Anyway, thank you very much for that semi-correct invitation, okay. All right. What is the difference between a nephrologist and a urologist? So just to be sure that you know that I'm not a urologist, because if you asked me to do that kind of work, I would botch things up, okay? A urologist is a subspecialty of surgery, okay? A nephrologist is a subspecialty of internal medicine, okay? You always can tell the difference between a urologist and a nephrologist at the elevator door. Do you know how to do that? You just watch. A urologist, when they come to an elevator door and it doesn't open, and when it starts opening, they will put their head in. A nephrologist never does that. They put their hands in. Do you get the connotation? Nephrologists use their head. Urologists don't use their heads. Okay, sorry. All right. So we're going to talk to you about the kidney today. Before doing that, I'd like to quote to you just a portion of Psalm 100 that I learned in 2nd grade in public school, and I won't tell you how many years ago because you'll start calculating. in your mind, okay? Make a joyful noise unto the Lord, all ye lands. Serve the Lord with gladness. Come before his presence with singing. Know ye that the Lord, he is God. Now, the words I want you to notice are these. It is he that has made us, not we ourselves. And I think as we think about the various organs and functions of our body, hopefully you will realize that it is a he that hath made us and not some evolutionary process. Have you not handed any of them out yet? Yes, go ahead and hand them out, fine. So we're going to talk about the kidneys today. And hopefully it will not be boring to you, but have some interest to you. And I'm hoping it'll show up okay. I'm going to block you. I'll move over here. Obviously, fall is coming. Isn't that the most beautiful time of year, I do think, okay? So go to New England or go up to Bishop or something and enjoy what you can see there in terms of the fall. Okay, the kidneys are located below the diaphragm and above the pelvis. And remember that that part of the body in the front is called the peritoneal cavity. And that part which is between the diaphragm and the pelvis in the back of the body is called the retroperitoneum, or behind it, okay? And that's where your kidneys are located, okay? Whoops, I did something the wrong button. I don't know where anyway. The kidneys, notice are a little lower on the right side because you're doing this from the back now, so you have to think about turned around. And you know why the kidney is a little lower on the right side than on the left? It's because the liver is on the right side and it pushes it down, okay? So the kidneys are back here, and most of those kidneys are protected by the ribs because just a small portion lies below the ribs. They're nice and protected by the ribs. So when you get hit and everything, you hit the ribs first, okay? And I don't know where the pointer is. Is that at the top, is it? I don't know. That's not it. Where's my helper? No, nothing.
Yeah, you blanked it, so we're going to hit. Maybe. It's weird. Let me go fix it.
Usually the first speaker always has the one that tests out the audio-visual. You never be the first speaker. Always pick to be the second one, okay? Let's see. Okay, the pointer is where now?
This one right here. So we're going to hit that.
Where are you pressing? Up the top.
This red line right there. Right
Okay, okay. I don't see a thing. Way up the top. You see anything? Anyway, audio-visual. Okay, I wish I had a pointer that works. Can you find the thing that works? Oh, you're seeing it.
It's this little bar right there.
That little one.
You should have a red mark, but it's gone.
How come it doesn't work for me? I'm not seeing it.
It's up on the ceiling.
Up higher?
Pull it down.
There you go. You got it.
Oh, there we go. Okay. Okay. So you have the right kidney and the left kidney, and they're about the size of your closed fist. And if I were to show you what a true human body looks like, kidney, this is it. This is from a human being. Split open, okay? This is the outside, the inside, okay? And that's about the size of normal kidneys, okay? Somebody used that at one time. And so you have the aorta coming down here, which is bringing blood to each kidney via the renal arteries, and then the blood goes back to the heart via the vena cava, okay? Now, there are normal kidneys, and there are people who have congenitally abnormal kidneys. This happens to be an example of a situation where you have an atrophic or hypotrophic left kidney, and that probably is not adding any function to the body, but if it's not giving any pathological problem, it's just left in. Some people are born with 3 kidneys. Some people are born with only 1 kidney. Some people are born with kidneys that are down here in the pelvic area, so you can have a lot of different congenital abnormalities. But they're about the size of your fist. Now, anybody knows about what % of your total body blood goes to the kidneys at any one time? What would you guess? What %? 5%? 10%? What? Okay. The thing is to remember that 25% of your total blood at any one time is going through the kidneys. That is a large percent. When you think you got the brain, you got the liver, you got the pancreas, you got the spleen, et cetera, et cetera. So the good Lord found out or knew that you needed those 2 kidneys. 25% of your blood at any time is going through those kidneys, okay? Okay, let's talk a little about the anatomy of the kidney. Okay, the outside of the kidney, the very outside, has a capsule around it known as Gleason's capsule, which protects it. And then the very outside of the kidney is known as the cortex of the kidney. The inner part of the kidney is known as the medulla or interstitium. And out here in the cortex are these little round things that we will talk more about, which are known as glomeruli. You have 1 million approximately glomeruli in each kidney, or 2 million of them normally. And that is where the urine is made, okay? Then these glomeruli have tubules that come down to these, what we call major calyces. And so each of these glomeruli have a tubule. And then the kidney brings down the urine to these major calyces, to the pelvis of the kidney, down the ureter, to the bladder, and out the urethra, okay? And we'll look at these more closely, okay? But this is the makings of a kidney, okay? Next one, let's see, okay. Now, let's look a little about the blood supply here, okay? So, you have the blood coming down the aorta, and it goes in the renal artery, and most of the time you're born with 1 artery to each kidney, but there may be 2, there may be 3 that are abnormal congenital abnormations. So you have a renal artery, and then you have the interlobular branch of the artery, the interlobular one, and then you have this little afferent arteriole that comes to the glomerulus, and then blood comes out of it as the efferent arteriole goes into the venous system, goes back to the inferior vena cava and back to the heart. That's sort of the circulation through the kidney, okay? Now, let's look at the glomerulus itself. Okay, here's the glomerulus, and you can think about this like a ball. And inside that ball are these capillary loops just winding around inside, okay? So the blood is brought to the glomerulus via the afferent arteriole, which has come from the aorta, circulates around in those little capillary loops, and then goes out via the efferent arteriole. And then these little capillaries eventually twine around all these, each tubule, and finally come out to a vein and go to the inferior vena cava and back to the heart. Now, see these lines around these capillaries? It's called the glomerular basement membrane of the glomerulus. glomerular basement membrane. That membrane is very important because inside these capillary loops is your blood, right? And these capillary glomerular basement membranes have to be normal because you don't want them to spill albumin from the blood into this space known as Bowman's space, which is where the urine is. You don't want to lose albumin, okay? So they can become diseased and lose albumin. You lose then a lot of albumin and become nephrotic or swollen up all over. They also can develop disease in these little glomerular basement membranes, okay? You also do not start spilling sugar out of the blood that's in these capillaries until your blood sugar gets above 200. Then it will spill it into this Bowman space, then down your urine, and you will measure sugar in your urine when it gets only above 200. In this blood that's circulating around these capillaries, of course, is sodium and potassium and calcium and magnesium and phosphorus and everything. And again, you don't lose any of these things into the urine or Bowman space and out the urine unless they're diseased. So these glomerular basement membranes circulating around here and covering these capillaries are very important, but can become diseased, okay? This whole thing together, the glomerulus, the proximal tubule, the loop of Henle, the distal nephron, the collecting tubule, all together is called a nephron. And that's why we are called nephrologists, because we deal with the nephron, okay? But that's what a normal nephron looks like, and you have about 1 million of each of these in each kidney, or approximately 2 million altogether. And when you start losing function of these nephron components, then you start having significant problems, okay? This is looking at one of those glomeruli through an electron microscope. And you can see the open capillary loops that I showed you. And these are the glomerular basement membranes. This is Bowman's space where the urine is formed coming through these glomerular basement membranes and then going down the proximal tubule and so on. But this is what a true glomerulus looks like under an electron microscope. 1 million of these in each kidney, okay? Now, what are the functions then of your kidney and my kidney? Well, I think most of us would say your kidneys make urine, period, okay? But they are marvelous organs, marvelous. Now, granted, they do excrete waste products. The main waste products that we talk about are urea and creatinine, and we'll be talking about these substances shortly. And this is why when kidneys fail, we call these people as being uremic. That's where the term comes from, because they can't get rid of urea, okay? So our kidneys are important to get rid of waste products, such as urea and creatinine, and we'll talk more about that. The kidneys are also important for controlling the volume within our vascular space, intravascular space. Now, most of us have about 5 to 6 liters of blood and plus water in that, and we can't lose all that, and sometimes we don't want to keep all of that. So the kidneys are very important in keeping fluid balance in our bodies. They are also important for keeping us in what we call acid-base balance. You can think about acid as being like vinegar and base like being baking soda. And we call, if we have normal vinegar and normal baking soda, we say that that normal pH of our body is 7.40. If you became acid, it drops down to 7.3, 7.2, 7.1, and death. If it gets alkaline or base, it goes up to 7.5, 7.6, and so on. But your kidneys are important for keeping that normal at 7.4. And we'll try to get into that a little more, okay? And not get too deep, okay? Actually, the kidneys also make hormones. Now, if you talked about your parathyroid glands, you'd probably know it makes parathyroid hormone. If you think of the ovaries, it makes estrogens, okay? The kidneys too make hormones, okay? They make a hormone which is known as renin, which then stimulates the production of another hormone, which is angiotensin, which is a vasoconstricting hormone. It'll make your vessels constrict. So if you got hypotensive, you'd start making more renin, more angiotensin to constrict your vessels to bring your pressure back up. This angiotensin also then stimulates another hormone from the adrenal glands, which make aldosterone, which help you hold on to sodium and get rid of potassium. So there's a lot of balance here, okay? So the kidneys make a hormone known as renin, which have an influence then on angiotensin and aldosterone. The kidneys also make another hormone known as 1,25-dihydroxy D3, which is the most active form of vitamin D, which then helps us in our control of calcium in the body. And lastly, the kidneys make a hormone known as erythropoietin, which stimulates the marrow of your blood, of your bones, to make red blood cells. Now, did you imagine that your kidney is doing all of that, other than just making urine? Okay. And so that's why when the kidneys go bad, a lot of things go bad. Okay? And we don't appreciate those things until those things happen. And the kidneys are also important in controlling various electrolytes. Electrolytes are like sodium, potassium, and so on. They're controlling calcium and phosphorus and magnesium. A horrendous amount of things those two organs are doing, okay? And that's why probably the good Lord is putting 25% of the blood flow at any one time to these organs. Okay. I got to go back up here. Let's see. Something's happening again. Top, very top. Stop moving.
You want to go back, or you want to go back or forward?
No, forward. Just there. Okay, thanks. Now, most of us put out about 2 liters of urine a day, 2 quarts. Believe it or not, those 2 organs of yours make 180 liters of urine a day. 180. And that means that all those 2 million nephrons, that's what they're making. But you don't put out down through those tubules in a day's time 180 liters. Because they know that most of that needs to be reabsorbed, but you made that because that urine, as it goes down through the tubules, has to now regulate your sodium and your potassium and all that, acid base and so on. So it's putting through all that quantity in order to accomplish the other things it has to accomplish as that urine goes down each of those 2 million glomeruli tubules. 180, you'd be going to the bathroom all the time. Okay? Now, how do you evaluate these kidneys to see how they're doing? Of course, you'd like to look at what they make, and so you want to look at their urine. And so we can do a microscopic examination. So we take some urine, we want to clean catch urine, we will spin it down, we will pour off the top of the urine, which we call the supernatant, and then the little button that's at the bottom of the glass cubicle thing, we will put on a microscope and look under it. And we look for such things as white blood cells, red blood cells, bacteria, casts, crystals, and so on. They should not be there. But say you find a lot of white cells in the urine and bacteria, it suggests to the doctor that you have a urinary tract infection. If you're showing red cells, of which there should be none in the urine, that might suggest a glomerulonephritis, might suggest a stone being passed, might suggest a tumor, et cetera, et cetera. So looking at the urine under the microscope tells us a lot. Then what you also do with that urine before you pour it off is in the supernatant, put a dipstick down, and on these dipsticks, which you just get out of a bottle, it measures whether there's sugar in the urine, whether there's albumin in the urine, whether there's blood in the urine, whether there's white cells in the urine by an enzyme known as WBCase, whether there's nitrates, which means they're bacteria producing nitrates. So just putting a dipstick tells you a lot about whether there's any abnormality in the urine that you should be concerned about, both by the microscopic examination and by the dipstick, okay? Now, you also can measure in their blood what we call the BUN, or the blood urea nitrogen. The normal is about 10 to 20 milligrams per deciliter. And remember, urea is not made by the kidneys. Urea is made in the liver. And it's made in the liver from the catabolism of amino acids. And that is converted to urea in the liver and then excreted by the kidneys, okay? And so if the kidneys are not functioning right, they don't get rid of urea, and an abnormality would be then an increased BUN above 20. The other chemical that you look at is creatinine, and creatinine is also not made in the kidneys. It is also made in the liver, and the normal is about 0.7 to 1.2 milligrams per deciliter, and it is made from creatine, which comes from muscle breakdown, which you're doing all the time. The creatinine goes to the liver and is made, the creatine goes to the liver and is made to creatinine and is excreted by the liver. So if you have a disease that's causing muscle breakdown, the creatinine really soars up because of all the creatinine being presented to it, okay? These are two valuable things that you look at, the BUN and creatinine. This is just showing the dipstick, using the microscope to look at it microscopically, okay? And this is looking at the different things that you can see in the urinalysis if you're a doc or a technician looking at things. You're looking for casts, you're looking for red cells, looking for white cells, looking for bacteria, on and on. But that's what the kidney makes. That's what you want to look at, is the urinalysis. In females, collecting a good clean catch urine is sometimes difficult because of some vaginal washback, and so sometimes you have to put a little cotton ball or something in there or something. In a male, same thing, you may also get contamination, but you want clean catch urinalysis so you don't make a wrong diagnosis. Another evaluation of the kidney is to collect 24 hours of urine. That means you void, throw it away, and save your urine for the next 24 hours and void the last urine of that 24-hour period in a bottle and bring it into the laboratory. And you're looking to see if there is an excess amount of protein. Let's see, where are we now? Okay. Excess amount of protein. You can, in the 24-hour urine, do what we call a creatinine clearance. I will not tell you the formula of that right now, but a normal creatinine clearance when you collect a 24-hour urine should be between 100 and 125 milliliters per minute. People who go into kidney failure requiring dialysis intervention usually are around 10 or 15 milliliters per minute and below. When you get that 24-hour urine, it's not good. We also refer to that as the glomerular filtration rate. If you happen to be a stone former, you can measure in that 24-hour urine calcium to see if it's calcium stones or uric acid stones, oxalate stones, and so on. So there's various things you can do with collecting a 24-hour urine and looking at it. To do a more rapid test to see if you're spilling abnormal protein, which you should not be spilling any protein in the urine, you just do a spot voided urine, and you measure the urine protein in that spot urine and the urine creatinine in that spot urine. And if that ratio is above 1, you are spilling an abnormal amount of protein and needs further evaluation. And you should not, through those glomerular basement membranes I told you about, you shouldn't be spilling albumin or globulins of any type. Shouldn't, otherwise there's disease. Now what's happened? It's not advancing for some reason. Okay, there we go. That's showing you how you collect a 24-hour urine. Void the first one, save everything in between, and save the very last one, okay. Okay. Now, other tests you can do is the plain x-ray of the abdomen. We call that a KUB, kidney, ureter, bladder. Just a plain x-ray of this abdomen. And about 80% of kidney stones can be seen on a plain x-ray of the abdomen. Some will not. And especially uric acid stones don't show up, and cystine stones frequently do not show up on a plain x-ray of the abdomen. The KUB also usually shows you your kidneys and perhaps their size, whether you have 2 kidneys or 1 kidney, whether they're enlarged, et cetera, et cetera. We don't do too many intravenous pyelograms, what we used to call IVPs. And the reason for that is to get an x-ray of the kidneys injecting iodinated dye is that some people get allergic to iodinated dye, and they can have what we call an anaphylactic reaction and seize and get hypotensive, et cetera, and die. And so since there are a lot safer tests to do today other than intravenous pyelograms, we tend to less use those today than we used to. This shows an IVP. You can see the kidneys. And remember I told you about the calyces, and then the pelvis of the kidney, and the ureters coming down. And it does show up the kidneys fairly nicely, okay? But again, because of the risk of iodinated dye, frequently you go to other tests today. A lot of tests is done by doing ultrasonography or renal ultrasound of the kidneys. And you can see here the kidney by ultrasound. And you can see whether it's enlarged, whether there's a tumor there, whether there's dilatation of the various collecting systems, et cetera. And it's a very benign test, but tells you a lot of information. It is not a good test for ruling out kidney stones. You will miss a lot of kidney stones. You can pick them up sometimes, but you will miss kidney stones by just depending upon a renal ultrasound. CAT scans are used nowadays. They can be given with contrast, that's iodinated contrast, or without contrast. And sometimes they use gadolinium, but it has its problems as well. But this involves radiation when you use a CAT scan. Ultrasound, no radiation. CAT scan can be with or without radiation. And the best test for looking for kidney stones is a CAT scan without contrast. A CAT scan without contrast is the best one for ruling out kidney stones. Then there's MRIs, which involves no radiation, okay? And that makes it advantageous. And it can be given with or without contrast. But the big value is no no radiation is given. And then you can give nuclear scans, which we call scintigraphy, where you inject radioactive material into a vein, and then you are scanning in a scanner the kidneys, and you can see them not lighting up until you injected them. Then you can see the 2 kidneys lighting up because of the isotope that you've injected. Then you can see it starting to move down the ureters more, then clearing out, okay? So this can tell you something about whether you've lost blood supply to a kidney, et cetera. You do not ever do this on a pregnant individual because you're giving radioactive material. But this is known as a renogram to look at the kidneys. Then we do sometimes renal angiograms, where you go with a catheter in through the femoral artery, up the iliacs, up the aorta, till you come to the renal arteries, and then you inject eye into each renal artery. This is normal renal artery, and sometimes you can have 2 renal arteries, 3, and so on, but most of the time 1 to each one. But notice this one is abnormal. So this is the aorta having contrast injected into it. But notice this little narrowing here. This is known as renal artery stenosis and is one of the causes for hypertension that you always look for a person as being etiologic in a person with hypertension. If it looks beaded, like little bumps, beads, it's fibromuscular dysplasia, and is another cause for renal artery stenosis. But this is a renal angiogram. If we're looking for a tumor of the kidney, we frequently also will do a renal angiogram because the contrast that you're injecting into the renal artery makes the tumor really light up very strong and suggests a tumor being present. And then sometimes we have to do a retrograde pyelogram. A retrograde pyelogram is where you go in through the urethra, go into the bladder, and then go in with your tubes up the ureters and inject iodinated contrast and do x-rays. That's a retrograde pyelogram. Intravenous pyelogram, this way, okay? And then there's such a thing as an antegrade pyelogram, which means you have nephrostomy tubes coming out from your kidneys outside to the flank, and you inject dye here, and so the dye goes antegrade this way, an antegrade pyelogram, looking for certain stones and obstruction of the ureteral system. And then sometimes we have to do a kidney biopsy, which we usually do under ultrasound guidance, having the patient lie on their belly and a pillow here to push the kidneys forward. We numb the area where the kidneys are. We can see where we are with the ultrasound, and with a needle, we go in and take a quick piece of tissue out of the inferior pole of the kidney, and then that is stained by 3 different processes: immunofluorescence, light microscopy, electron microscopy, and it can tell us what the disease process is of the glomeruli, or out here in the tubules, or out here in what we call the interstitium, which is around the tubules. So that is a more invasive test, obviously. Okay, talking some about kidney failures, which do fail on us. And so you can divide kidney failure into being acute. That means, remember I said the normal creatinine is about 1.0 milligrams per deciliter. So say that's what my creatinine is today, and tomorrow it's 3 milligrams per deciliter. That is acute rise in this normal toxin that's gotten rid of by the kidneys, but it's not getting rid of. Acute kidney failure, okay? And then there's chronic renal failure, which is a more indolent, slow progression downhill of your kidney function. So there's 2 kinds, acute and chronic renal failure. Acute renal failure is you hope you have a type of acute renal failure that will recover function on its own, and that they may only have to be put on dialysis for a short period of time and then come back off the kidney machine. That's what you hope. People with chronic progressive renal failure have to then either be faced with dialysis for life or a possible transplant if they meet criteria for that. People with acute renal failure can have different manifestations. They can have what we call oliguric acute renal failure, meaning that over a 24-hour period, they're putting out less than 400 milliliters of urine, but still putting out some urine. Non-oliguric would be that their creatinine and BUN are still going up acutely, but they're still putting out more than 400 milliliters of urine per day. Anuric means that they're essentially not putting out any urine, but maybe less than 100 urine per 24 hours. And when you have a person who is not putting out any urine, you have to think of obstruction, so they can't get out, or you have to think of renal vascular catastrophe. No blood's getting through to make any urine, okay? Those are 2 big things you think about when you have an anuric patient with renal failure. And a few rare causes with renal failure acute are polyuric. They're still putting out a lot of urine, but their BUN and creatinine are going up. So there's different types. So if a doctor is seeing a patient whose creatinine has gone up from 2 to 3 to 4 over a number of days, and you're thinking of acute, doctors need to know more and more about non-dependability upon autonomic machinery, but a history of the patient. You gotta ask some questions of the patient that might make you think of the acuteness. Did the patient take some drug that is toxic to the kidneys? That could be picked up and made a diagnosis right away, et cetera, et cetera. Good physical examination important. Never forget that as a physician, as a nurse, whatever you are. Then do your laboratory studies, and we said, obviously, you want to do the BUN and creatinine. You want to see what the electrolytes are, because particularly with renal failure, one of the big things you can get is high potassium, hyperkalemia, and that can cause sudden cardiac death. Boom. Your normal potassium in the blood is 3.5 to 5.0. Very narrow range of normality. And your creatinine could go up, now normal is 3.5 to 5. It could go up to 7 and you're dead. Just a little. So, you've got to follow some of these electrolytes very closely. In a patient with acute renal failure, you want to consider doing various imaging studies. You do something that hopefully will not cause more toxicity, such as giving them iodinated dye, in some contrast, or gadolinium, etc. And occasionally you might have to do a kidney biopsy to find out the etiology for their acute kidney failure. Now, when you're dealing with a patient with acute renal failure, it's good to think into 3 subgroups etiologically for their acute renal failure. We call that, is it pre-renal, is it renal, or is it post-renal? Pre-renal, we mean that there is hypoperfusion to the kidneys. Remember, you have the aorta and you have the renal artery coming down. And so, sorry, I am not used to this doodaddy. Okay, let's see if I get my finger here. Is there something causing hypoperfusion to the kidney? That could be that you develop an arrhythmia, or you've gone into congestive heart failure, you had a myocardial infarction, and you're not perfusing the kidneys. A lot of things. We'll show you about that. Or has something happened to be toxic to inside the kidney? That's renal or intrinsic. Or is there something that is obstructing the kidneys, such as ureter, bladder, urethra, okay? So when we think of various pre-renal causes for acute kidney failure, we're talking about hypoperfusion, pump failure, heart failure. Are you volume depleted? You people call it dehydrated. Do you have relative hypotension? That means that you have been a hypertensive patient and your blood pressure is usually running 170 over 90. Not good. But now your blood pressure is 140 over 60. That may be relative hypotension. The kidneys, because of long-standing hypertension, now have constricted their vessels and need that higher perfusion rate, and you bring it down to normal, they don't perfuse. Relative hypotension. People who tend to like to use alcohol not uncommonly get alcoholic cirrhosis. And they then develop liver failure, hepato, and because of their liver failure, they simultaneously get kidney failure. It's known as hepatorenal syndrome. And when these people get bad cirrhosis, they get big abdomen with ascites, and they get edematous, they get jaundiced, etc. And what is really happening is now their kidney fails also, and that's because the vessels inside the belly all constrict, and then your kidneys don't perfuse. So the liver has failed, and now the kidneys fail. Hepatorenal syndrome, frequently leading to death. Now, you might say, NSAIDs, I take Advil or ibuprofen or I take this or that. What do I do? NSAIDs, I must say, are good medications if they're taken the right way. But they do have side effects, just like a plain aspirin tablet can have side effects. But they have to be watched out for because they can do numerous things in an abnormal way, which I don't have time to go through all of those. But I don't want you writing off NSAIDs from your armamentarium. Other hypoperfusion would be renal artery stenosis or renal vein occlusion, so you can't get blood going through the kidneys, et cetera, et cetera. Then there's post-renal, which means anything coming out. And that becomes a long list, which you can see in your house. So the doctor has to think when there is obstruction, is there obstruction down here at the urethra, which is commonly the prostate, but it could be other things. Is the obstruction occurring with something in the bladder? Is it obstruction occurring with somewhere in the ureter, such as a stone, such as a cancer, et cetera, et cetera? Is the ureter being obstructed because of pressure from the outside that's compressing it? And that can be tumor, it can be retroperitoneal fibrosis, et cetera, et cetera. So you have to think of all these steps from bottom all the way up to top in terms of obstruction causes for acute renal failure, and you can read those through on your handout. Now, when you go to intrinsic, so we had pre-renal, you have post-renal, and you have renal or intrinsic, something gone wrong within the kidney itself. And the most common ones that we deal with are acute tubular necrosis. Excuse me when I hit the wrong one. Where's my light now? Light. I can't. Anyway, ATN is a common one, acute tubular necrosis. Let me tell you the story of how do you remember acute tubular necrosis. Out in the mountains behind Yucaipa and Calamasa and Loma Linda, people like to go up for snow skiing, snowboarding, etc. And this one gal one Sunday decided to go up and go tubing and come down a little chute in a tube. And so she did, having a good time, and crashed into one of the pine trees. And because of the impact that she had, she ruptured her liver, she ruptured her spleen, she got a pneumothorax, she got muscle damage or rhabdomyolysis. All of these things put together caused acute renal failure. And she was only about 30-some years of age. And she, because of the hypoperfusion, or thus the ischemia, or lack of blood supply and oxygen to those kidneys, the tubules get necrosed, or develop what we call acute tubular necrosis. And you hope that you could put these people on dialysis, and after maybe 3 or 4 weeks, they could regain function and come off dialysis. She was very fortunate to be such a one. There are others that do not recover from whatever the cause of acute tubular necrosis, and we'll talk more about that in a second, but require then dialysis for life or transplant if it's not contraindicated. Acute interstitial nephritis I'll talk to you about, but those are the two very common causes of intrinsic acute renal failure. Acute cortical necrosis means dead kidneys, done. Cortical necrosis, the cortex of the kidney, too ischemic, never to recover. Then there's all types of glomerulonephritis. The ones you know about is post-streptococcal, strep throat, and so on, but all types of glomerulonephritis. Acute vasculitis, polyarteritis, and so on and so forth. Then we have diseases that cause loss of platelets or dysfunction, such as with bad infections, DIC, disseminated intravascular clotting, hemolytic uremic syndrome. And then we have tumor lysis syndrome, and that some tumors release a lot of substance that causes uric acid to go sky high, and acute failure from uric acid. So a doctor has to try to weed through all these things as etiologic causes for a patient with acute renal failure. So acute tubular necrosis, which is a very common cause of acute renal failure, can be oliguric or non-oliguric, and I define those. It can be reversible or irreversible. What you're hoping for is you have an ATN patient who is non-oliguric, so they don't have to restrict fluids, and that is reversible, and they can come off dialysis. Okay, so ATN, which is a very common cause for acute renal failure, can be caused by severe ischemia to the kidneys, which is the one I sort of defined in the snow. But then notice iodinated contrast is a big cause for ATN and acute renal failure. And that's why we don't want to be throwing around iodinated contrast. I don't say don't use it, but you'd like to be sure that the patient is well hydrated before they get iodinated contrast given to them. You want to try to use low molecular weight type iodinated medication, and you try to use as little volume of it as possible. Different things. You try to have the patient off NSAIDs in that before they do it, and so on. So there's certain precautions that you need to do if you're going to give iodinated contrast. It's more likely to occur in people that have impaired kidney function already, and then you give an iodinated contrast. And the same can hold true with gadolinium. Antibiotics are life-saving, so I'm not saying don't use antibiotics. But there are certain antibiotics that are kidney toxic, such as aminoglycosides. Those are like gentamicin, tobramycin, etc. Vancomycin, which is lots of times needed for staphylococcal infections. Even some of your cephalosporins, which are like your Keflin and so on. NSAIDs themselves can be nephrotoxic. Carbon tetrachloride, which is cleaning solution. Illegal drugs like cocaine and some of these things. Colistin, cisplatin, which is used in treatment of cancer sometimes. Insecticides, there's just a whole bunch. That doesn't say you don't use these. They can be life-saving and must be used. But you need to know you're dealing with something that you have to monitor their levels, keep them hydrated, et cetera, et cetera. You have to know what you're doing, okay, when you're using. And then we have endogenous toxins. A lot of people who are in bad motorcycle accidents or car accidents, et cetera, have a lot of muscle injury, crunch. And that causes what we call rhabdomyolysis and releases myoglobin. And that myoglobin starts circulating through the kidneys and shuts them down. Rhabdomyolysis. Electrocution will do the same thing. And then hemolysis, a common thing would be a blood transfusion reaction. That releases not myoglobin, but hemoglobin and so on, free, can be toxic. Then we have acute interstitial nephritis. Remember we said we have the tubules, the glomeruli, the tubules and so on. But then we have the cement or the interstitium where the tubules come down to the calyces. And that is a sort of an allergic reaction where the lining outside the tubules get all inflamed. And typical causes are penicillins and cephalosporins, sulfa drugs such as Septra, Bactrim, and so on. NSAIDs, again, are incriminated in a lot of things. Quinolones, Cipro, leprofloxacin has been incriminated, and other miscellaneous drugs. So a lot of, and this is why a good history is important when you're diagnosing acute renal failure, is to see whether the patient is exposed to any of these drugs I've talked to you about. When you have acute interstitial nephritis, again, medication exposure is important. They frequently develop some rash. They have drug fever. In the blood, they have a lot of eosinophils, which are cells that increase with allergy. They have white cells in their urine, but no bacteria grow out. It's sterile pyuria. They have eosinophils in the urine. When you look at it under the microscope, may have blood, rising BUN and creatinine. If you do a kidney biopsy, you'll find the inside of the kidney around the tubules is packed with eosinophils, allergic, acute interstitial nephritis. You can see the glomerulus, but notice the tubules, but look at all those cells, just packed. That is an allergic reaction to the kidney, acute interstitial nephritis. If you have it, stop the offending drug and never take it again. Don't take it again. And the doctor should know that, okay? And sometimes we treat them with a short course of steroids to hasten the recovery. Not commonly do they require dialysis, but occasionally do not, but they usually, fortunately, do get better. Chronic kidney disease, in closing, I think pretty much. Two most common causes of chronic kidney failure. Gone. Diabetes and hypertension. Two diseases that can be prevented from causing kidney failure. Which one do you think is the most common to cause chronic kidney failure, type 1 or type 2? Type 2? 1? Okay. Type 1 is the most common cause to cause kidney failure. But most of the people who have kidney failure from diabetes are type 2 because there's so many more type 2 diabetics than there are type 1s. But type 1 is the most likely one to do it. But you have a lot of type 2. I'm type 2. And I've had it for years. Creatinine is 1.0 yet, but I try to watch it, okay. But diabetes is something that doesn't have to do it if you get treated right. But it's the most common cause. Hypertension, another thing, is a big cause for chronic kidney failure and is a treatable thing. And people just need to get treated right for it. Then you've got all types of glomerular disease, that ball with all the capillaries in it, all types of glomerular disease. There's genetic disease such as polycystic kidney disease, where they get big, huge kidneys from cysts. There is hereditary nephritis, which usually occurs in males and carried by females. I had a mother and father who had 2 boys. The mother carried the gene for hereditary nephritis and gave it to both the sons, and they both were on dialysis, and we transplanted both of them. That's hereditary nephritis. Also has deafness with it and some other things. Hereditary nephritis. Then some other miscellaneous things for chronic kidney failure. Analgesic nephropathy, we usually saw a lot of that when people took APCs, aspirin, phenacetin, and caffeine, APCs. The phenacetin was the big culprit and caused kidney failure. You can still get it from a lot of long-term pain medicines, including even NSAIDs as well. Analgesic nephropathy. Obstructive uropathy, we've talked about. Heavy metal poisoning. Kids used to get a lot of lead poisoning. That's because most of your paint had lead in it. And your cribs were painted with paint with lead in it. And they would chew them. And they'd get lead poisoning. Unfortunately, lead is taken out of gasoline today and so on. We see less lead poisoning today. We talked about renal artery disease, such as renal artery stenosis and so on, and other congenital diseases. Obviously, I can't cover everything, but just to give you a smattering. Complications of renal failure, be it acute or chronic. Okay, one of the big things is anemia. Your normal hemoglobin, 12, 13, 14, 15, and so on. Why did they become anemic, you think? Testing you out. I taught you this already. I failed. The kidneys make a hormone known as erythropoietin that stimulates the marrow to make red cells. And if you go in kidney failure, you don't make the hormone. And I've practiced nephrology long enough. When we didn't have it, we now have that drug available. We can give erythropoietin intravenously, sub-Q, intramuscularly, and prevent the anemia. But I used to see patients when we had erythropoietin, we had to transfuse them, and then they started getting transfusion reactions, and all kinds of problems. They got iron overloaded. We gave them all this transfusions with iron in it. Bad. And I used to see people in dialysis with hemoglobins of 3 and 4 because we couldn't give them blood anymore because they were allergic to anything now. We couldn't give them that. So nowadays, you're lucky we have erythropoietin. Metabolic acidosis. The kidneys are important for keeping our pH 7.4. What are the two organs that help keep us in normal pH, acid-base balance? What are the two organs? Kidneys. What's the other organ? Liver. Lungs. Okay. I will use this one board for this. I hope this isn't too boring for you. There is a formula known as the Henderson-Hasselbalch equations, which is pH equals the pKa of blood plus the log of bicarbonate over pCO2. A normal pH, I don't know what's happening here, is 7.40. This is a fixed constant, which is 6.1. This is the Henderson-Hasselbalch equation. I will not go how it's derived. Plus the log of bicarbonate, and your normal bicarbonate is about 24. And this is formulated by Henderson-Hasselbalch. The normal pCO2, or CO2, which is what the lungs take care of, is 40 millimeters of mercury. This times this is 1.2. 1.2. This is 24. So 1.2 into 24 goes 12. The log of 12 is 1.3. 1.3 added to that is 7.4. I am having problems with this and that. Anyway, you take care of that. So the two organs that keep us in normal pH are our lungs, by whether they blow off CO2 or don't. If you blow off too much CO2, you get basic or alkaline. You retain too much CO2, like an emphysema patient, you get acidotic. Your kidneys are important for the bicarbonate aspect here. And a thing that is really what we call acid in the body is hydrogen ion, hydrogen H ion, hydrogen. And the kidneys, both of them are important for getting rid of hydrogen ion and regenerating bicarbonate. So that's taking care of the kidney aspect. So both of those organs are important for keeping us in acid-base balance. So if this one goes wrong, this one tries to compensate. If this one goes wrong, your marvelous body tries to compensate by this one. What the body was made for, okay, to compensate. Okay. Now, when you and I eat protein, it breaks down into sulfuric acid and phosphoric acid. If you've ever taken chemistry, you know those are strong acids. They will burn your skin. They will burn everything. Sulfuric acid and phosphoric acid. They have hydrogen ion on them. The kidneys, because of the protein, have to get rid of that hydrogen ion and regenerate bicarbonate to take care of your acid base. And if your kidneys don't work, you get acidemic with kidney failures because they can't get rid of hydrogen and they can't regenerate bicarbonate. Okay? Whereas carbohydrate and lipids, or fats, break down to CO2 and water, not sulfuric acid and phosphoric acid. So the lungs take care of the CO2 from from fats and sugars. Okay. So acid base is very important being taken care of. Oh, let's see, where we are. We're about finished, I think. Okay, potential complication of renal failure is hyperkalemia. The kidneys are very important for getting rid of potassium. And so when their kidneys are failing, what do I tell them? Do not take orange juice, bananas, tomatoes, avocados, etc., because they're high in potassium. And you just need to move, remember, in the normal is 3.5 to 5, and so if you move from 5 to 6 to 7, you could be dead. So you have to restrict potassium, or you're going to cause cardiac toxicity. And don't take potassium chloride. Okay? Peripheral neuropathy, these people get numbness and tingling and restless legs. They can't find a comfortable position to put their legs. They lose their reflexes, or they get hyperreflexic, and if they come into you with kidney failure and you put your wrist out like that and they go, boop, 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 we call it asterixis. They are near having a grand mal seizure and they need to be put on dialysis right away. Bad neuropathy, very hyper-irritable. Sleepy, want to sleep all the time. Poor appetite, nausea, vomiting. They can get uremic pericarditis. Remember, your heart is in a sac known as the pericardium that can get inflamed and get a lot of fluid around the heart, and the heart cannot pump because it's being compressed by all that fluid in the sac around the heart, and grand mal seizures. This shows the hyperkalemia. You do it down by an EKG, and notice these let's see, I've got to go a little higher. Anyway, see these waves that are very high? Chip, way like a thing. Those are peak T waves. That is an implication of severe hyperkalemia and should tell the doctor they better get treated right away. Okay, conservative treatment, avoid nephrotoxic drugs. You may, if they're in oliguric failure, restrict fluids, restrict sodium because that's going to add to fluid retention, restrict potassium. They retain phosphorus, so you restrict phosphorus, such as dairy products and so on. And you may have to take medicine that binds phosphate and they get rid of it by the gut, and just a bunch of those different things. If their iron studies are normal, then you may wish to give them erythropoietin, and that saves us from giving a lot of transfusions now. With people with kidney failure, you don't give them magnesium, such as milk of magnesia, mag citrate, Mylanta, because they can't get rid of that magnesium. They get hypermagnesemia and get paralyzed. Modify medicines that are handled by the kidney. And you may want to not, like if you have a person on digoxin or lanoxin, you have to reduce the dose. If they're on allopurinol, you have to reduce the dose. Just a bunch of medicines you have to either not give them or reduce the dose if they have renal failure. Indications for acute dialysis: hyperkalemia, which cannot be controlled medically, cardiac death. Fluid overload: if they cannot get rid of the fluid, you've got to take off the fluid with dialysis. Metabolic acidosis, which cannot be controlled medically, dialysis. If they show evidence of clonus, hyperreflexia, asterixis, dialysis. If they have evidence of uremic pericarditis, and I'll show you a picture of that, these are all indications to dialyze a patient. See that big, huge heart? That's because the sac that's around the heart inside, the cavity around that sac is full of fluids and is going to compromise kidney and heart failure. Pericardial effusion. Otherwise, we stick a needle in and draw the fluid off. Okay, I think I'm going to skip a little of this. So stages of kidney failure: stage 1 is when your GFR creatinine clearance, which we said was 100 to 125, is somewhere greater than 90. Stage 2 kidney failure is 60 to 90 milliliters. Stage 3 is somewhere between 30 and 50. Stage 4, which usually means nearing dialysis, when your GFR or 24-hour creatinine clearance is less than 30. So when you come to dialysis, you're either left with hemodialysis, which can be done in an inpatient unit or can be done in an outpatient unit, peritoneal dialysis through the belly. If there are no contraindications, a kidney transplant, which can be from a deceased donor, a living related donor, or a living unrelated donor, providing you have ABO compatibility and HLA typing okay. And some people don't want dialysis of any type, don't want a transplant, and just ultimately die from their disease process. So approximately 700,000 Americans have end-stage renal disease at any one time. Greater than 500,000 are currently on dialysis. The greatest number of these on dialysis are on hemodialysis. Only about 10% of people decide to go on peritoneal dialysis. It's mainly funded by Medicare. If they don't have Medicare or Medi-Cal, then state has to do that. Average life expectancy on hemodialysis is less than 3 years, but some people live 20 to 30 years. Major cause of death on dialysis is cardiovascular. The main cause of death with transplant is infection. And it's costing the government to help people with dialysis now, probably now close to $150 billion a year to keep people alive. And I think that is the end. This is just showing a patient on the left on hemodialysis and one on peritoneal dialysis, which you can do at home. So that's a quick, rapid view of your poor kidneys that you were fearfully and wonderfully made to have and use. Anything else? See if there's any questions before we let them go. Fly seat around here.
Sir, my question has to do with potassium. I understand that the body is trying to get rid of potassium, and I understood before today that we needed potassium. So what amount of potassium is healthy in the body?
As long as your kidneys are working fine, you can eat all you want.
Okay.
It
It's
needs to
just
be
when
kept
they're-
between 3.5 and 5.0.
3.5.
So in other words, if you decide you want to take a lot of diuretics, which may be diuretics that make your kidney lose potassium, then you're going to have to substitute and take it potassium to keep it 3.5 to 5.
Okay.
But what I'm saying is that you have a very narrow margin
Right.
there, 3.5 to 5. That's where it has to stay. And with kidneys, they're important. And it normally, if you decide you want to eat potassium, and your kidneys are working fine, you will not even think about it, but your kidneys will get rid of it.
Healthy kidney.
Wonderful. But if they're not working well, they can't get rid of it, and then can't.
Well, my
gotta
friend
stop.
had
Okay.
low potassium 2 times and went to the ER, and I don't know what caused that.
So you're on the low side.
She was depleted.
2 is on the low side. That's bad too.
Right, and so they were saying you need potassium and you're low. So I thought potassium was good. I didn't realize there's such a small, narrow.
So you can have
healthy-
problems on both sides. You can get
Right.
cardiac arrhythmias with low potassium, and you get mark weakness and all this and that.
Okay, thank you.
Yeah.
Very interesting.
But I mean, the marvelous thing is that most of us don't in this room have to think about how much potassium. Go ahead and eat it, as long as your kidneys are fine, okay? But
A couple of questions. On dry fasting, where you're fasting without drinking water, at what point does that get dangerous for your kidneys, do you think?
okay, there is such a thing as polydipsia, which means people who like to drink water, drink water, drink water, drink water, okay? That's being polydipsia, drink dipsia, okay? Poly, too much. And most of the time, you know, your body will dump that because your volume expanding them. You then shut off antidiuretic hormone, which means then you'll pee it out. But there is a point where you can exhaust the body and drink too much water. And that is, there is a disease known as psychogenic polydipsia. Something is telling that person, I got to drink more, I got to drink more, I got to drink more. I've only had one patient in all my nephrological, so it's rare. And that can cause problems because if you cannot get rid of all that water, it's going to dilute out your sodium. And your normal sodium in your blood is about 135 to 145 milliequivalents per liter. And so if you drink so much water, it's not going to be 135, it's going to go down 130, 125, 120. And that can cause severe neurological problems and so on.
How about the other side, about not drinking water? If you didn't drink water for 3 days, is that challenging?
If you drink how much in 3?
Zero amount of water.
Oh, so your body should, you know, being lacking water, will try to conserve as much as they can, okay? You are going to get into problem, though, whether it's at 3 days or what. I mean, you lose water by various means. You lose what we call insensible loss, simply by breathing. You're losing water through your skin every day. You lose probably about a liter a day, insensible-wise. That insensible loss goes up if you're hyperventilating, which could be by running or anything else like that. Or it's high ambient temperatures, and you're going to lose more by the skin, so your insensible losses go up more. That means that you should be replacing that, plus you're losing water in your urine, some in your stool. But I mean, you have to take into consideration all these different things that are affecting your water balance. But you are going to get in problems on both sides of the coin if you decide to just restrict water like mad. Your body's going to try to correct for that by putting out like more antidiuretic hormone, which means all the water coming through your tubules is going to be reabsorbed into the body. But eventually it's going to give up, okay? So you can get in problem both in a hypodipsic state and a polydipsic state. But your body tries to compensate it as long as it can.
And along those lines, I've heard of runners that do long-distance running having kidney failure at some point. And I was wondering, what is the process that's causing that? Like, especially on people that run a marathon. Like, they can actually have a lot of problems with their kidneys. Is that also caused by the being dehydrated, or is
Okay,
it just
can
pushing too much?
you come forward? I'm not got bilateral hearing aids. I'm not hearing it quite right.
Yes, sir. Long-distance runners? Long-distance runners.
Okay, that's good.
When they're running long distance, they have kidney
Running long
problems.
distances.
They have kidney problems. Actually, you can have severe kidney problems after certain points. And I'm just wondering, is that the same process? Is it about the loss of fluids, dehydration, or is it more about pushing too much blood through your kidneys, can't do it, and you start having problems on that side?
You know, again, I'd have to see the patient, but one of the things I would think with severe running could cause rhabdomyolysis, muscle breakdown. muscle breakdown. And when you have muscle breakdown, you're going to release myoglobin. And myoglobin is toxic to the kidneys, just like release of red cells releasing hemoglobin. So you get hemoglobinuria or myoglobinuria, and that both causes acute tubular necrosis and kidney failure. That would probably be the most likely thing that you would see. Now, granted, with severe running and increased loss of insensible losses, et cetera, you could get electrolyte problems. Certainly with a rhabdomyolysis, not only are you releasing myoglobin, but cells have a lot more potassium in them than out here in the blood. And they release potassium. And you can get, you're not perfusing the kidneys because your volume depleted, you can't get rid of potassium, you get hyperkalemic, cardiac death. It's just da-da-da-da-da. Okay.
Any more question?
Can I ask you, doctor? My mom was hospitalized in ICU 4 days ago because
Supervisors,
of
okay.
low salt.
Okay.
Right now, she cannot drink water. She drink only water, 500 milligram, one bottle for 24 hours.
That's my water she can take in.
Yeah.
So she has a problem with hyponatremia?
Oh, yeah, that's the one.
Hypo, low sodium.
Then
So
they
you-
disconnect to her kidney too, because
Your
her kidney.
question is,
My question, the doctor prohibited her to drink up too much water. It was only one bottle for 24 hours.
yeah, like I say,
millimeter.
our normal insensible losses through our breathing, through our skin, through normal urine output would be about 2 liters or 2 quarts a day. So she's only taking in a half of a liter a day,
Yeah, half
or
of a liter a
500
day.
milliliters.
No, for 24 hours, not a half of a day. 24 hours.
24 hours,
For-
500
For
milliliters.
half, yeah, 500 milliliters.
So that's really restricting.
Restrict
yeah.
him, because according to her doctor, that the salt is loose by drinking too much water, was away. So she shouldn't have any salt inside in her body.
Her sodium should come up.
A little
blood
bit,
sodium.
a little bit,
Yeah.
without the
But
too
that's-
much drink of water.
Yeah, but that is real strict restriction.
Yeah.
I mean, because
So-
she is normally losing about 2 liters or 2,000.
Yeah.
She's taking
That's
in
the
500.
problem.
So you lose that too much, you're going to potentially get into problem with volume depletion and not perfusing kidneys and things like that.
Yeah, that's
Granted, the sodium may
connected
go
to
up.
her kidney too.
So if they're going to do that restricted, they need to follow her very closely, including her blood studies and so on.
Yeah, that's the one. We
Got it.
are all going all the time to the doctor.
Got to get them checked closely.
A week,
Yeah.
every week.
That may not even be enough, I mean, and again, if she's restricting down to 500 and she goes out in this, no, it's not hot weather now, but when we were having 110, she's going to get into problem because she's going to lose more insensible losses. She's only taking in 500, she's going to get into problem. She'd have to be monitored very closely.
Yeah. Besides that, she had a high blood pressure, high too.
Type 2.
The blood pressure of my mom is 161.
Mm.
So that's a problem for two.
Yeah.
According to her kidney. According to the doctor, because her age is 87, is a shrinking, the kidney is a shrink because of her age too.
Yeah. Well, she's going to have to be monitored very closely.
Yeah,
with that,
very
I think,
closely.
Very closely.
That's why I have to bring her
Okay.
in the church, because nobody will
Okay,
watch
and
her.
be sure in this hot weather, if she's restricting down to 500, she stays in an air-conditioned area.
Yeah, that's
Okay.
the way, yeah.
Okay.
So, what you're gonna advise, the extension advice for my mom for that, I'm talking about with you,
What was the question?
the low sodium.
What is your advice?
Advice for us.
Well, not knowing the whole etiologic cause for this, I would hate to start guessing any cause, true treatment, okay, as to what to do beyond what he's doing, okay. In other words, you have to find why she tends to be hyponatremic, okay. And that could be adrenal insufficiency, it could be on, and so the doctor has to put her through a number of tests to see why in the world first she was hyponatremic. and then try to give the right treatment for it. And for me to kind of guess all of those things now would be difficult, I think. Okay?
Okay.
Okay,
Okay.
sorry.
So,
But watch her if that's what she's on right now, okay?
yeah,
Watch her.
just help us to pray for her.
Very good.
Because right now she is not,
Thank you, thank you.
yeah, it's ongoing observation.
Yeah, good. Best to you, Mike.
But she's here with me.
Okay, about one more question, then we probably will let you people go, or else it's going to be
Okay.
supper time.
One more question.
Or you can grab me after.
Okay, so in your presentation, it said that NSAIDs can cause kidney problems, right?
What has
Okay.
kidney problems?
In the presentation, you said that NSAIDs can cause
NSAIDs, okay.
Can acetaminophen do that too, or no?
Tylenol or acetaminophen? No, the main thing would be with acetaminophen is taking more than, most people say 4 grams a day, and then you can get into liver toxicity. But it does not have, it's not classified as an NSAID. Aspirin is, and Motrin and all these are NSAIDs, okay, but Tylenol or acetaminophen is not an NSAID. But the main problem with taking too much Tylenol is liver toxicity.
Okay, thank you.
Okay. Okay, why don't the rest of you just sort of stay after if you have some questions. The price isn't any greater than what it was before. But hopefully it wasn't too complicated or too lengthy. But nephrologists are known for long notes, long consultations, and still have to work to 83 before they can retire.
Thank you so much, Dr. Bob. Let's give him a round of applause, please.
Thank you all for that. Okay, but stay if you have any questions, and we'll try. It's okay. Okay. Have a good Sabbath and a good week.
Dr. Bob, this is our the token of our appreciation to you.
Isn't that nice?
Yeah, certificate of appreciation for sharing your knowledge about kidneys. It's
Well,
a lot of information for us.
It's good to share it once in a
absorb.
while because the synapses begin forgetting it after a while. Thank you. Okay. Thank you for inviting me, okay? Thank you all for coming.
Let's have a prayer. Our most gracious, loving Heavenly Father, we thank you once again for the health message that we've learned. Help us to apply whatever we learn into our daily life to keep our body healthy, worthy to be a temple for you to reside in us. In Jesus' name, amen.
Amen. Thank you, thank you. Okay, well. They are glorious organ. It's